My name is Nick Bartelo, and I will be talking about metabolomic-driven discovery of 7 type 2 diabetes progression groups within a pre-diabetic population. I have no conflicts of interest. Today, we'll be talking about metabolomic markers of type 2 diabetes that are known. Then we'll define prediabetes. We'll define what the problem is that we're trying to tackle. Then we'll talk about how we created our pre-diabetic patients using the UK Biobank, which is our data source. And then finally, we'll talk about the determination of these naturally occurring pre-diabetic patient subgroups using unsupervised clustering with solely 168 metabolomic features. Here we show that there are known metabolomic biomarkers for type 2 diabetes. Weill et al. Created this figure, and what it shows is that within the carbohydrate metabolism, amino acid metabolism, and lipid metabolism, that there are known associations with different metabolomic features to incident type 2 diabetes. And those that are darker shades of the color shown here are negatively associated with type 2 diabetes, meaning that increased expression of these metabolomic features actually has been shown to have associations with less type 2 diabetes. And it's opposite for those that are in the brighter colors. So next, Ferret et al., through a meta-analysis of these 8 studies, found pooled relative risk of associated type 2 diabetes biomarkers, shown here. And what this showed is that patients with increased levels of these biomarkers at baseline had either a higher risk of incident type 2 diabetes or a lower risk of incident type 2 diabetes. And we boxed in red a few of these metabolomic features, which we will see later on in our own study. Next, we define prediabetes. Now, the gold standard measurements in the clinic for defining these stages of diabetes progression are the glycated hemoglobin, or HbA1c, and fasting blood glucose. FPG is fasting plasma glucose here. And we see that as a patient progresses through the stages of type 2 diabetes, that they start normal, and so there's a normal glycemia with traditionally these ranges here, and then they become pre-diabetic, and finally they become diabetic. And these measurements, although they give an indication of what stage a patient is at, do not say much about the underlying biology. So now we move to the problem. And the problem is that type 2 diabetes is heterogeneous. This means that the patients who develop type 2 diabetes do so in a number of ways. There's not one path in which each diabetic takes to develop this disease. Also, there are variable treatment responses. And what this means is that not one treatment will help each and every patient. It's not one size fits all. So the goal here is to uncover this heterogeneity of type 2 diabetes, and we want to do this before the progression. So to do that, we use pre-diabetics. And what this does is it results in the ability to, 1, prioritize pre-diabetics with the greatest risk of developing type 2 diabetes, and 2, provides insight into the different mechanisms of type 2 diabetes progression. So what makes this research special is that we use only pre-diabetic patients. This is important because right now, over 1 in 3 patients in America are pre-diabetic. And currently, many methods of risk assessment for type 2 diabetes progression incorporate healthy patients, which does not give you a reliable result for these 1 in 3 pre-diabetics. So we wanted to create something that used only pre-diabetic patients, which results in a more reliable interpretation. Next, we talk about how we created our pre-diabetic population from the UK Biobank. And we use the Mayo Clinic's recommended ranges for pre-diabetics of an HbA1c between 42 to 47 millimole per mole, of fasting blood glucose between 5.6 to 7 millimole per liter, and we also incorporated patients who had a pre-diabetic ICD-10 code R73 before their measurements were taken, which necessarily means that they were pre-diabetic at measurement time. So next, we wanted to find those patients who were pre-diabetic at baseline measurement, who throughout the study, which was about 15 years, those who progressed to type 2 diabetes and those who have not yet progressed to type 2 diabetes. And in the red boxes here, we show that the methods in which the criteria in which we specified for this are self-diagnosed patients who say that they progress to type 2 diabetes later on in the study, or doctor-diagnosed or billed through an ICD-10 code patients, pre-diabetics, who later progress to type 2 diabetes within the study. And for those who do not progress to type 2 diabetes, we did this by finding confirmations by healthcare institutions that these patients had not progressed to type 2 diabetes, or if a pre-diabetic ICD-10 code was designated to these patients before the start of the study, and they did not have a type 2 diabetes ICD-10 code E11 in the rest of this study, or if a follow-up visit for these pre-diabetics showed that they were diagnosed with a disease after 2018 that was not type 2 diabetes, shown by this E11 ICD-10 code, that these patients are being checked up on and going to the healthcare provider, and therefore if they had developed type 2 diabetes, they would have a designation. So using these criteria, we find about 10,000 pre-diabetic patients who we are confident that they either progressed to type 2 diabetes within the study or do not progress to type 2 diabetes within the study. Now, unfortunately, only about 24% of these pre-diabetics had metabolomic data taken. And so when cutting down for this, we find that we have a final cohort of 2,339 patients, 1,243 patients which are confirmed not to progress to type 2 diabetes, and 1,096 patients who are confirmed to progress to type 2 diabetes during this study. Finally, we come to our point where we determine these naturally occurring pre-diabetic patient subgroups. So a little bit about the method. First, we normalize metabolomic values by this min-max normalization. Basically, this just cuts down the variability due to measurement tools and units used for each metabolomic value. We next performed agglomerative hierarchical clustering with complete linkage using correlation distance for 168 metabolomic features. This distance formula is found here, and basically what it does is it just allows us to show a representation of how far apart, how different two metabolites are from each other. So the outcome of this clustering is this determination of these 7 natural patient groups shown on the y-axis here. And so each of these rows represent a different patient, and so these patients all correspond to group 1, these patients correspond to group 2, and so on. On the x-axis here, you see the metabolites. So this means that for each of these rows, these values are corresponding to different metabolite expression values for each patient. And we see that there are huge differences between groups, shown by the contrasting colors of the expression values of each group. So on the right here, you see a donut chart in which the outside circle shows the distribution of these total 2,339 pre-diabetic patients at baseline into each of these groups. And we see that there are differing sizes for each group. And on the inside, we show the progression proportions for patients within these groups. So green shows those that do not progress, and red shows those that do progress. And we see that there are differences in the proportions for all groups. So what metabolomic features drove the creation of these groups? To better understand how these groups form, we found unique underexpressed metabolites, which means that these values were lower in patients in a certain group compared to the patients of the other groups, or overexpressed, which means that these metabolites they had larger values in a certain group of patients compared to the other groups of patients. And what we find here is that we find specific metabolites to each group that either have a positive, a negative, or an inconclusive correlation with type 2 diabetes found in previous literature. And the overall trend here is that groups 1, 2, and 3 tend to have a significantly expressed metabolites in a direction such that their correlation with type 2 diabetes means that these patients typically are healthier. We're expecting them to be healthier and not progress to type 2 diabetes as much as the other patient groups, specifically group 4 and group 7, which have metabolomic features and that are underexpressed and overexpressed, coupled with a correlation with type 2 diabetes, such that these patients have a higher risk of developing type 2 diabetes. So then we asked what clinical outcomes characterize these groups. On the left here, you see the proportions of patients, pre-diabetic patients in each group progressing to type 2 diabetes. And we see that group 3 and group 1 have the smallest proportion progression, whereas group 6 and group 7 have the largest proportion progression. Now, when we look at the average days to type 2 diabetes progression, we find that those patients who progress to type 2 diabetes within group 7 progress at the fastest rate, whereas those in groups 1 and group 3 progress at the slowest rate. So this shows that there is some variability in the clinical outcomes of our groups. We further explored this using these progression curves, and this statistical analysis shows that our previous explanations were correct, that groups 1 and group 3 statistically their progressors progress to type 2 diabetes at a slower rate than the other groups, whereas group 6 and group 7 progress at the fastest rate to type 2 diabetes compared to the other groups. And so then we asked what traditional risk factors are associated with group differentiation. And traditional risk factors are just clinical demographic variables that are typically used in assessing type 2 diabetes risk. So here we had 32 measured variables in which we found these 21 specific traditional risk factors that were significantly expressed in one or more groups. In this figure, we show the traditional risk factors which have statistically significant expression in group 1, circled in red, and group 3, circled in yellow. Each traditional risk factor is abbreviated so that the graph does not fill with text. The edges connect the significant TRFs to each group. Blue edges represent TRFs in the group that are significantly underexpressed, while red edges represent TRFs in the group that are significantly overexpressed. The takeaway of this graph is that while some TRFs exhibit the same expression for both groups, such as HDL-C, which is HDL cholesterol, a majority of the TRFs are either expressed in the opposite direction between the two groups, such as C, which stands for cholesterol, and DBP, which stands for diastolic blood pressure, or are uniquely expressed by one of the two groups, such as age for group 1 and PC, which is platelet count for group 3, When looking at the type 2 diabetes progression graphs, these graphs show almost identical results. Therefore, clinically, these patients would look the same, but we showed that there are specific mechanisms at play that influence the final phenotypes. This demonstrates an instance of the heterogeneity between pre-diabetics with almost identical outcomes. We also wanted to compare group 6 and group 7 directly, and we did this, and we show that the main difference here is this overexpression of HDL cholesterol in group 6 and an underexpression of HDL cholesterol in group 7. And so we see that group 6 performs better in a clinical sense, such that less people progress to type 2 diabetes, and it takes longer for them to progress to type 2 diabetes. Now, we hypothesize that this could be caused by the overexpression in group 6 omega-3 fatty acids that was not found in any other group. So for our conclusions, we discovered these natural groupings of pre-diabetic patients with significantly different type 2 diabetes progression outcomes. We identified unique metabolomic features responsible for the separation of these groups. And finally, we created networks which revealed different biomarker expression patterns for groups that are very similar in clinical outcomes, showing that we can tease apart this heterogeneity of type 2 diabetes. And I'd just like to thank a few people from my lab, mainly Matthew Wickersham, Scott Kalm, and my PI, Olivier Elemento. Thank you.